Hi, my name is Karen Mariner. I'm a licensed health and life insurance agent in California. My company is Cal Health Agent. You can find us at calhealthagent.com. This video is meant to introduce you to the concepts of Medicare, the terminology of Medicare, and make it easier for us to work together so that when we talk on the phone, you have a basis of understanding and we can cut through to what's really important and really relevant for you. So, without further ado, let's get started. It's about a 30-minute video. I'm sorry, but it's just not easy to fit um, Medicare concepts into a small bit of time. So, I'm going to share my screen, go to PowerPoint, and get going. I call this video Medicare Alphabet Soup because people really do get very, very confused about the different letters of the parts of Medicare and the various ways to fill the gaps. So first of all, we have Part A. Part A is your hospital insurance. This is what Medicare calls itself: hospital coverage. Your inpatient care while you're in the hospital, skilled nursing, hospice, home health. Part B covers professional fees, doctors, physical therapists, therapists, that have a contract with Medicare, outpatient care, home health care, some preventive services to maintain your health and keep you from getting sicker. And I say some because there are some that are also not covered. Um, Medicare Part C, which is usually called Medicare Advantage. This is a program that is, where Medicare is giving your benefits to a private company that has a contract. They agree and to provide Part A and B benefits to people with Medicare as well or better than what they would get directly from the government with what we call original Medicare. Medicare Part C is the prescription drug plan. These are both considered Advantage plans, which is very confusing, but Medicare Advantage covers prescription drugs also. And then we have what we call the standalone prescription drug plans. This is Part D. You cannot have both. You can't have C and D. You have to have either one or the other. So, what does Part A cover? Part A is, first of all, how do you get in it? It's automatic if you're receiving Social Security. So if you're already collecting Social Security when you turn 65, you're going to get a card in the mail. At age 65 or after 25 months of being on federal disability, you're also eligible for Medicare. Premium free for most people if they're eligible for Social Security or they or their spouse of over 10 years paid into the Medicare system, paid at Medicare taxes for at least 40 quarters. The hospital coverage, inpatient room and board, skilled nursing, not custodial care, but this is skilled nursing, usually referred to as rehab. Hospice, respite care, and some home health, nursing, physical therapy, occupational therapy, speech, and the cost of blood. Part A, what are the out-of-pocket costs? Hospital. You get admitted to the hospital as an inpatient, you are facing a $1,736 deductible right away. If you have the unusual situation of being in the hospital longer than 60 days, from day 61 through day 90, the copay is $434 a day. And over day 91, $868 per day. And let me explain that there is no out of pocket maximum on Medicare. So if you found yourself in a situation where you had a very long hospitalization, you could run up a very, very big bill. And hospice care is also covered by Part A. Regardless if you're on original Medicare or Medicare Advantage, hospice care is covered by Medicare Part A. Part A also covers skilled nursing. If you've had a 3-day hospitalization, then you are covered for rehab, and this is the kind of care that is intended to get you back home, get you strong enough and get you back home, days 1 through 20. And then beyond day 20, you're looking at a $217 per day copay. And then I said the cost of blood, usually not any copay. Enrollment, Centers for Medicare and Medicaid Services now recommends that everybody who is eligible for Part A, when they're first eligible, even if they're on an employer group plan and they're not ready to begin their full Medicare benefits, they are encouraging everybody to enroll in Part A. Basically, raise your hand and say, I'm 65, I'm ready for Part A. And then you'll get a card in the mail, red, white, and blue card with your Medicare claim number, and it'll say Part A, hospital benefits only. And that's great because you hang on to that. You'll need it later when you decide it's time to retire. And as I said earlier, it's premium free with 40 quarters of Medicare taxes paid. Part B is what we call medical coverage, what the government calls medical coverage. It's optional, so you can delay your Part B enrollment if you're on a group medical plan and you're actively working. The monthly premium is income dependent. It is a sliding scale from the standard 202.90 to as high as 689.90. And we'll talk about that in a couple minutes. The enrollment period is 3 months prior to the month in which you turn 65. Medicare, your Medicare eligibility is day 1 of the month in which you turn 65. Part B coverage, doctors, outpatient care such as procedures, testing, a welcome to Medicare visit within the first 12 months of you being on Medicare, and an annual wellness check, which is slightly different than a typical physical. And you can, do a little bit of research on that, but this is how Medicare covers your preventive is with this annual wellness visit. Preventive care and some vaccinations are covered on Part B, some are covered on Part D, and ambulance. Cancer screenings, chemo meds, these are the kinds of medications that your doctor orders, and then you go into an office or a clinic and they infuse or inject this medicine into your body. You do not, go to a drugstore and pick up chemo. So we call these Part B medications, and they tend to cost you a lot less out of pocket than if they had been on Part D, for example. So I get a lot of questions about this, but Part B medications are infused or injected into your body. Diabetes screenings and supplies, DME, such as CPAP, is covered on Part B, and limited chiropractor and acupuncture, acupuncture care for specifically low back pain. Occupational therapy, PT, and lab. What are the out-of-pocket? We talked about the premium a minute ago. The standard premium for Part B in 2026 is $202.90 per month. And the deductible in 2026 is $283 for the year. So very low numbers. Coinsurance is 20% of whatever Medicare approves that care to be. So if you go to a doctor visit and the doctor charges Medicare $200 and Medicare says, that's worth $100. We'll pay you $100. Medicare immediately will pay $80, and that leaves the $20 left over for you. You can delay Part B enrollment if you're working actively through your 65th birthday. This special enrollment period lasts for 8 months after your coverage and your active work ends. There is no gap in coverage typically. The Part B will begin the day after your group benefits end. The process is that the employer completes and signs this CMS form, L564, which essentially communicates to the Social Security Administration that you have been covered by a group plan and working actively since you became eligible for Medicare Part A. That's what this form communicates. The process is that you apply using a special link in the Social Security website, and then you upload this signed form. If you'd like to see what this process looks like, I do a screen share demo on a video, and you can find that on my Cal Health Agent YouTube channel. Go ahead and subscribe. It'd be great. I upload new videos every time I come up with something I think that people ought to know about, and I end up repeating myself a lot. I try to make a video so that my clients can watch and learn at their own convenience. Here is a table of the IRMA surcharges. IRMA stands for Income Related Medicare Adjustment Amount. I'm going to talk about it for a minute, then you might want to pause the video just so you can, find out where you might fall in this table. So 2026 surcharges are based on 2024 modified adjusted gross. So when you enroll in Medicare Part B, the government gets you enrolled and then checks with the IRS to pull your 2024 modified adjusted gross. If, let's say, you're a single income tax filer and your adjusted gross in 2024 was over 109,000 up here, then you're going to pay double for Part B if it's over 109. Let's say it's between 109 and 137. If it's less than 109, there is no IRMA. And many times, people have a very, very different income 2 years ago than they do now, because now they're retiring and they're losing a bunch of income. So there is a process where you submit a form to the Social Security Administration. It's called Form 44. You may want to note that down in case that you're in this category. And Form 44 says, I know you looked at 2024 and you saw my corporate income and it was higher than 109, let's say. But now that I've retired, my income projection for the current year, 2026, is going to be, less than 109,000 or between 109 and 137, and you were like way up here, let's say. So there's a process because many people go on Medicare and retire. And so looking at their income 2 years ago is not reflective of reality for the year that they're in. So, if this is you, I spend a fair amount of time with my clients on this, but just know that it's Form 44 that you submit after you're assessed an IRMA surcharge. Here is the Part D surcharges. They're much, much lower than Part B, but they do exist, and I wanted you to know about them. Advantage plans. So we talked about Part A and Part B. Here's Part C, which is one way that is sometimes referred to in the Advantage program. So the beneficiary assigns Part A and B to private health plan. These are for-profit companies for the most part. You really should use in-network doctors, even if you're on a PPO model, in order to minimize your out-of-pocket spending. Only emergency and urgently needed services outside of the US, outside of the plan itself, worldwide. So let's say you're in a plan in Northern California, and then you travel to visit family somewhere outside of California, and someone says, you really ought to see my dermatologist for what's going on with you. This is not urgent, but I think you should see this doctor. That is not going to be covered by a Medicare Advantage plan. That is not urgent or emergency. Plans can use prior approval, prior authorization to deny care. And we have seen doctors actually leave the network in the middle of the year, which kind of leaves their patients in a pickle. Plans tend to be 1 year. Many plans stick around for more than that, but we've had a lot of turnover of plans here in Northern California, in particular in Contra Costa County where I am, and we really only have one viable plan outside of Kaiser at this point in Contra Costa. So a lot of change in this market, a lot of profit in this market, and follow the money. It's not always great for the beneficiary. We'll talk more about that. Part D are the standalone drug plans. The government does not handle drugs. These are benefits that are provided by private companies such as WellCare and Cigna Health Spring and United Healthcare and Blue Shield. That's the kind of companies you'll see that are the Part D companies. We call them PDP, prescription drug plans. Medicare Advantage plans like the HMOs and PPOs, they include the drug coverage. So we call them Medicare Advantage prescription drug, MAPD. With Part D plans, there are two coverage phases at this point, the deductible phase and the initial coverage phase. There used to be four phases. So these plans have gotten much more simplified, thank goodness. And for the first time, we actually have an out-of-pocket maximum for spending on covered medications. This was a part of the Inflation Reduction Act that President Biden signed into law. Last year was the very first year we ever had an out-of-pocket maximum on the Part D plans, and it has really helped a number of my clients that are on expensive brand name medications. So as long as the medications are covered, they're included under this $2,100 cap. I send out, this is a quick PSA for my clients that are on original Medicare with a standalone drug plan. I send out a video every year on October 15th with a demo of how to use Medicare.gov to evaluate what plan is best for you for the following year. Please look for this video. Put a little tickler in your calendar on October 15th. Did I see Karen's video? Check with Karen. Is there a video? Go to my YouTube channel. It's really important because once December 7th rolls around, that's it. There's no more changes. And the Part D program does have late enrollment. So even if you don't take any drugs, it's really important to enroll yourself in a Part D plan. We have zero premium plans, $5 plans. So there's really no barrier to getting in a drug plan. What are the gaps in Medicare as of this year? So there's the deductibles and copays we've already talked about, vision, dental, hearing benefits, long-term care not included in Medicare. And what are some of the options to fill the gaps? Well, there's the supplement or Medigap plan. This fills most of the gaps inherent in original Medicare. These plans are portable throughout the US. The plans have absolutely no control over the care that you get. So I have to probably say this a couple of times. There's no network. There's no prior authorization. If Medicare covers the claim, the Medigap plan covers the bits and pieces that are left over, the copays and deductibles. Medicare supplements get paired with a standalone drug plan that we just talked about. And Medicare supplements offer you, the Medicare beneficiary, the most flexibility. On the other side of the coin, there's the Medicare Advantage privatization program. This is where you assign your benefits to a for-profit or private company. There's HMO and PPOs. HMOs, which actually create more profit for the companies, are the predominant model in the Advantage program. We are seeing PPOs close throughout the country because they just aren't as profitable. And they do have a lower monthly premium, but we'll get to in a couple of minutes that they can have a high out-of-pocket maximum. Drug coverage, as I said earlier, is included. Here's like a spectrum of the costs of Medicare, just inherent in the cost, right? So first, there's a deductible. We talked about that over here. There's the Part A and Part B deductibles. Then Medicare covers 80% of Medicare A and B. Then there's the 20% left over. That's a gap. And then some providers charge what's called excess charges. I'm not going to spend a lot of time on this. It's not common, but some providers don't accept assignment of Medicare, and they can then come back to the beneficiary and say, well, Medicare paid me this much, but I need you to pay me another bunch of money because I'm the world's greatest cardiologist and I don't accept Medicare assignment. So we'll talk about how to get these gaps filled. So there are 6 widely available Medicare supplement models across the US. A, you can see A through N. G is the most comprehensive Medigap plan available nowadays. Unless you're somebody who's been on Medicare before 2020, those folks have access to an overpriced model called F, which doesn't make any financial sense. So I'm not going to talk about it. I don't want to waste your time. All MedSup plans are guaranteed renewable. They offer you flexibility and the freedom to choose your providers, any doctor, any hospital, any specialist that hasn't opted out of Medicare, which is a rare thing. Med supplements have no referrals, no networks. Remember, everything is the same pattern. If Medicare covers the claim, the supplement covers the bits and pieces that are left over. All companies follow, the same set of federal and state laws. Costs vary by the company, your home zip code, and the plan or the model that you select. Some plans have different premiums, they have different claims experience, and they have different rates of, stability in the market. So they also have different brand recognition, and they, sort of capitalize on their brand. Here's a sort of a busy slide that you might want to pause for a minute after I introduce it to you. So it's just over here on the left are big categories of out-of-pocket expenses, and then the various model letters that how they treat those expenses. So you can see that Model G over here is the most comprehensive available. Not only does it cover 80% of foreign travel emergency, but it offers this $50,000 lifetime maximum for foreign travel emergency. So it'll pay 80% of your travel emergency up to 50,000 during your lifetime. There is, the N plan does the same thing. They are the only ones that have the foreign travel emergency. Medicare is not great for worldwide travel. So, it is fantastic for domestic travel. You could go to a hospital in New York or Texas or Minnesota, and it's as if you were at a hospital in California. Worldwide, a little lean. So we have this foreign travel emergency benefit to fill in that gap. Medical underwriting, if you're not in a guaranteed issue period of time, medical underwriting is still alive. It's the only place in our health insurance system where insurance companies can still ask medical questions and ask about your medications and your various, doctor, whatever, your doctor names and your conditions that you are living with. You can change supplements from carrier to carrier laterally. We have something called the California birthday rule, which states that if you're in a G, you can move to any other G during the 90 days around your birthday. For the SUPs, open enrollment begins when you're new to Medicare Part B and lasts for 6 months. So if you delayed your Part B because you continued to work past 65, then just know that you need to get into a supplement within 6 months of beginning your Part B, or you'll have to answer medical questions. How are they priced? In California, all of the supplements are priced attained age. So as you have the luxury and privilege and blessing of living another year, you will pay more for your Medicare supplement. Either every year you'll see an increase or every other year. They don't tend to be huge. The plans also have inflationary increases, and sometimes it feels a lot when people get both an age-related increase and an inflation-related increase. Doesn't happen all that often, but from a percentage basis, people can feel like it's a bit much and they want to shop around. So during their birthday rule period, that's when we shop around and see if there might be a better rate. On the Advantage side, this is where you're assigning your Parts A and B to a private health plan. You must use network doctors and hospitals, especially if you're in an HMO model. And you can minimize your out of pocket even in a PPO by staying in network. Emergency and urgently needed care outside of your coverage area are covered worldwide. That has to be. You're having an emergency and you're in New York, you're going to be covered as if you're in network. If you get out of network care without a prior approval from the plan, and it's not emergency or urgent, then you'll have to pay for that care on your own. They offer this 1-year contract I mentioned earlier, and they do include many value-added benefits, such as vision, transportation, routine podiatry, over-the-counter spending, and basic dental. Understand that these are the window dressing benefits. The plan wants you to pick their plan. They are extremely profitable plans. The government pays between $1,700 and $2,000 per month per person, whether you use any care or not, to the plan. And they're going to throw in, to varying extents, they're going to throw in these value-added benefits because they don't cost much, and what they're really after is that per member per month fee that they get from the government. The pros are the same low premium. These are not attained age rated. Everyone pays the same premium for the same Advantage plan. The value-added benefits I just mentioned, care management, primary care doctor, and they are guaranteed issue. There are no medical questions to get into an Advantage plan. Our annual enrollment period is between October 15th and December 7th. And this is the period of time to reevaluate your Advantage plan if you have a choice. The arguments against they are primarily HMOs. So it really is a tight network. You really do need to stay in network or be referred out and get a network exception. They tend to have maximum out of pocket of between $3,000 and $6,000. So unlike a supplement, going the supplement route where your max out of pocket is just your Part B deductible. Remember that number is $283 in 2026. So you're looking at paying more per month for a supplement, maybe as much as, $170 to $200 a month versus $70 a month for an Advantage plan. But on a supplement, you don't have to worry about having any unexpected medical expenses out of pocket because you are capped at $283 or that Part B deductible. Whereas on an Advantage plan, is more of a pay-as-you-go model. And then another little distinction I like to make for people is if you have a disagreement around medical necessity and you're on an Advantage plan, it's the medical group that the government is paying. So it could be Sutter, it could be John Muir, it could be UC. It's the medical group that makes the clinical decisions on your behalf. If you're on original Medicare with a supplement and a drug plan, the other way to fill the gaps, it's the government that you're appealing to if you don't agree with the medical necessity decision. And the government actually has very specific timelines to get back to you. Whereas a medical group, it's a lot more murky and opaque. And these are for-profit corporations, the medical groups, and they don't always have great call centers and client relationship management programs and systems. So people wait longer to get the answers to their appeals. And then before I let you go, I just want you to know that long-term care is not covered by Medicare. What is long-term care? It's custodial care. These policies that are meant to pay for all or part of your long-term care, custodial care needs are fully medically underwritten. So very important that you lock in these policies when your health is very good. Policies can be structured to meet your budget. There aren't that many carriers left in California. we as agents have to have additional certifications, testing, and I went above and beyond and did the CLTC during COVID, and I've kept that up. So look for an agent with the CLTC designation, because the different model types, like I have listed here, traditional, hybrid models, and single premium models, are confusing and complicated, and they fit in with your financial plan. So your financial advisor may be the best person to talk to about this. But if they don't if they don't maintain the long-term care certification, then reach out to me, and we can talk about long-term care for you if you think your health is good enough at this point in time. And why do you work with an agent? I'm licensed by the Department of Insurance, state of California. You, as the beneficiary, receive a lot of mail about Medicare. If you start Googling, you start talking to friends and family who aren't licensed, they can get you very, very confused. So a good agent can, untangle a bowl of spaghetti that you just might not understand yourself, and you get tired of using the computer to try to put these things together. Um, Part D, excuse me, the drug plans is a pretty complex program, and you can really save a lot of money by being in the right Part D plan based on the medications that you're currently taking. Um, Same. This bullet is really the same thing about out-of-pocket drug costs. There is no cost to working with an agent, so that's a question I get pretty often. We do act as advocates, at least we do here at Cal Health Agent. And lastly, we do the data entry, we do the computer work, so you don't have to, so you can enjoy your retirement. Um, Thank you. I'm sorry for how long this was, but I really appreciate um, you being attentive and taking this so seriously. So um, I look forward to speaking with you, and you can always reach out to me, Karen at calhealthagent.com. Thank you.